I'd like to thank Kyle for inviting me to give this talk, which was an interesting topic when he approached me. I had no experience with third parties because at MD Anderson we have 50 plus physicists, clinical physicists, and we pretty much do everything in-house. But recently we have started getting network sites and partner sites around the country, and I've been involved with doing some of the initial site visits to make sure that these different sites are up to the MD Anderson mark. And so some of my experiences are in this talk. So why this session? There's increased use of third-party services and products. A lot of hospital administrators find it easier and cheaper to hire consulting physicists, dosimetrists, physics assistants instead of hiring full-time people because your benefits and healthcare and all that kind of stuff. So they save some costs by getting people to just come in and do the job and leave. An increased level of complexity. There's more complex treatment planning systems, delivery system, and treatment techniques. And so if a third-party person comes and does some work in your clinic, you need, as the site physicist, you need to make sure that whatever they've done is correct. And kind of John kind of iterated to that a little bit in his talk. In the past 10 years, we have seen lots of serious incidents involving treatment planning systems mistakes, and the New York incident, treatment delivery systems, treatment planning mistakes around the world, and brachytherapy mistakes. And so it's very important that us as physicists, qualified medical physicists, that we take ownership of this and verify what someone else has done. There are many AAPM task reports and MPPG reports more recently giving you recommendations how to go about helping and guiding you how to go about taking care of these things. It's kind of interesting, just before this talk, I met one of my students from 20 years ago, and he's a consulting physicist. He travels around the country, and he spends time in a certain place for like a year or so. And he says this affects him as well as a third party because he goes into a site and he's on Monday and he's expected to sign plans, check charts, do QA on the machine. And he has no clue. Some of these places don't have annual reports, there's no commissioning documents. And so third parties could be anyone independent of what you are in your center at the given time. So it affects everyone. The motivation for this talk is also if a therapist makes a mistake, it'll be one fraction that was affected in one patient. If a physician makes a mistake, affected is the one patient, if the anatomy is wrong or the PTV is not properly contoured, for example. If a physicist makes a mistake, all patients treated through the duration of the mistake are affected, which is a big deal. It happened at some centers in the US several years ago. Linac or treatment planning system, a mistake, all patients planned or treated until the mistake is caught. So if there's a mistake in your treatment planning system, you're harming every single patient that goes through your treatment planning system. So it's very important that all these things are corrected up front before you release it for patient care. I won't spend too much time on this definition, but this has come from one of the AAPM task reports. A QMP must certify that the therapy units and planning systems are performing according to specifications, generate beam data, and outline written QA procedures, which include tests to be performed, tolerance, and frequency of the test. So pretty much you own the Linac or tomotherapy unit or CyberKnife. This talk is more geared at the Linac, but this could be any equipment that you may have. And it's your responsibility, that's your job, to make sure everything is working correctly. So I Googled, I went on different websites, different consulting companies, and one of my friends actually owns a consulting company. This is from his website. It says here, so this is showing a timeline. So if you look at the third-party website, this is what they claim, that they can commission a treatment planning system and a Linac in 6 days. I mean, they have to be superhumans to be able to do this in 6 days, but they're experts at this. That's all they do. They may have 10 physicists on site doing all this work. But they're promising administrators that they can do this, and administrators are going to probably hire them versus coming to me and I'll say 6 to 8 weeks that I can do this job. If you look at TG106 or MPPG 5A, it's more realistic. It's about 50 days, assuming there's about 1.5 to 2 FTEs working 12 to 16 hours. That's a long day. So that's why we have residents, I guess, who can work in the evenings and help us capture some beam data. So there's a big variability in what third-party vendors can promising to deliver. There's also vendors who have beam matching or golden beam data facilities available. So you can call a vendor, if you have 2 Linacs, they come in and you pay them a few $1,000s and they'll match energy to energy within about 0.5%, the depth of some profiles from one machine to another machine, which is useful if you have a big site. They also provide you golden beam data for your treatment planning commissioning. And you put the data in the treatment planning commissioning and it's all automated, you get the answer. However, you need to be careful because your machine may not match this golden beam data. Why? Each Linac is not a twin of the other Linac. There are slight differences in manufacturing, for example, the flattening filter. There's a lot of mechanical parts that go into these Linacs, and they're slightly different from each other. They're close, but not identical. When the Linac engineer comes on site, they have on-site changes to the beam. They're changing depth dose, and it's bending magnetic voltage, making sure your profiles are just what you like. This may not be the same as the golden beam data. It might be slightly different. The wedges may work differently. Commissioning process may uncover potential problems that may not otherwise be discovered. And so it's very important that you really thoroughly commission your Linac, and then you can use the golden beam data to compare against the data you got. So I'm going to spend some time on Linac and TPS commissioning. I won't spend too much time on it because John kind of covers some parts of this. But if a Linac is commissioned by a third party, it is the duty of the site's qualified medical affairs to ensure that all work has been performed appropriately and correctly. And how do you go about doing this? So like John said, you don't go and commission the machine again. You don't have the time to do this. But I would spot check it. If I was going to a new clinic in the middle of nowhere and I became the physicist, I want to make sure that the machine I'm inheriting from the previous physicist is up to par. And so you do spot checks. You check the TG50, which doesn't take a couple of hours. You can do OSLD measurement. You can get OSLD from the RDS or IROC and do an output check of the machine. It's an independent check, and that's very important. In our clinic, every Linac, annually we do OSLD checks, which checks the output of each machine in our clinic. You run a couple of treatment plans on it. If you commission a new treatment planning system, you run head and neck, prostate, thoracic plans on the old treatment planning system, and then on the new treatment planning system, you calculate them to see how close these different treatment planning systems are to each other. You should have a bank of patient cases, maybe about 25 to 30 patient cases from different anatomical sites, complex and simple cases, and you can run them on the Linac, IMRT QA, VMAT QA on these to see how this, it's a trend. So over the last 15, 20 years, you can keep a track record of what your results should look like. So when you get a new Linac, you do the same thing over and over again. So the QMP should consolidate all tests, data, and results performed by third-party vendors and generate Linac and TPS commission reports and data books. John kind of mentioned that in his talk. And that's very important. There are many sites that I have visited have nothing. I asked them, where's your commission report? So they pull out their clips or Pinnacle or whatever, and on the screen they show me the modeling. And I said, that's not sufficient. You need to show me a commissioning document. And what have you done to check this commissioning from some third-party person? And you need to have data books, machine data books that are on the machine. You need to have an end-to-end test. A lot of sites don't do end-to-end tests, and I'm going to talk a little bit about the end-to-end test shortly. So MPPG, which came out in 2015, is a very good document. It kind of tells you, kind of guides you through the commissioning process. So, things like CT calibration data. You want to make sure that what's in your treatment planning system is the CT scanner that you have on your site. It should be the same CT to density, the graph. It can't be some other CT scanner that was, with the third-party person put it in there by mistake. You need to review all the raw beam data going into a treatment planning system. You need to make sure that it's correct. Garbage in gives you garbage, out. So, all the data going into a treatment planning system should be checked. Beam modeling completed per vendor recommendation. Photon electron beam models, including heterogeneity, evaluated qualitatively and quantitatively. IMRT validation end-to-end test, like I suggested earlier. And then you set up the baseline QA. Once you're happy with all the commissioning work, you set up your baseline QA to do your TG142 and to monitor your machine and your treatment planning system for the years to come. Small field dosimetry is a little bit more complicated, so there's a special section in MPPG 5 talking about small fields, MLC commissioning. This is where people get into trouble. If you don't commission the leaf gap or the leakage or intra-leaf leakage and things like that with the appropriate detectors, you can get into trouble. Your plans may run hot or cold by a couple of %. So it's very important. And again, every treatment planning system, whether it's Ray Station, Pinnacle, Eclipse, they all handle these things differently. They all have different optimization and things work different in each system. So you need to understand the treatment planning system very well before you start working on the commissioning aspect of it and talk to the vendor and see how does this handle, how is the leaf gap or things like that handled in the treatment planning system. Small field output factor should be measured for beam modeling and verification. So here there's a nice table in this document telling you about some tolerances. For the PTV area, for example, if you're doing an ion chamber, it's about 2% prescribed dose. That's low homogeneity area. It's more homogeneous. And the organs at risk region, where there's some gradient, 3%. If you're doing some kind of planar dosimetry for doing a QA, for example, IMRT, VMAT QA, or like ARC check for volumetric array, they suggested 2%, 2 millimeter, not 3%, 3 millimeter like most people use. The reason for that is an asterisk at the bottom of the thing here. It suggests that if there are some mistakes in the treatment planning you're commissioning, it'll let you pick it up by going to a tighter tolerance. And if you're doing an end-to-end test like a Phantom, you can run it through the system, CT scan it, treatment plan it, deliver it, and look at the results. It's a 5% tolerance. So I went back to our resident and I said, hey, you know, this is kind of interesting. Let's go and look at some of our cases. So we randomly picked some cases in the clinic. And you know, here's some prostate, there's some base of tongue, head and neck, esophagus, brain. If you look at a very loose 5% 3 millimeter gamma and 90% pixels passing, it's about 99%. They all did really good. If you go to the more ubiquitous 3% 3 millimeters, again, they're doing pretty good. In most clinics, this is what we use. You know, everyone's happy. You know, you can sleep peacefully at night. But you change it to 2% 2 millimeters, look at the esophagus case. Suddenly the passing passed to 80%, a big drop. And now you can see if this is an ARC check, is what we use here for this study. And you can look at all the diodes which are on the harder side. So there's a slight difference between 3% to 2% on the ARC check, and obviously your gamma is off. So you got to go back and look as to why is that happening. Kind of, you know, you need to stop and pause and see what's going on. So a good thing, end-to-end check is an IROC Phantom. So every consulting site that we have around the country, I recommend to them that you need to get this IROC Phantom. It's an end-to-end test. It's independent from anything in your clinic. So it takes about 2-3 months. That's the only weakness because they have a limited number of Phantoms that go around the world. It's about $500, I think, approximately, to get these Phantoms. They have lung Phantoms, head and neck Phantoms, SBRT Phantoms. And this particular Phantom is a head and neck Phantom. There's a primary PTV and a secondary PTV and an organ at risk, which is right here. And so it's very simple. You get the Phantom, and then you ask your therapist, not you, ask your therapist to simulate or scan the Phantom, because that's what, you know, they're the ones scanning the patients. In this case, the prescription is about 6.6 gray to the PTV, about 5.4 gray to the secondary PTV, and the organ at risk is about 4.5 gray. And so you plan it. In this Phantom, there are some TLDs and some FEM. They're in different planes along the axial and along sagittal planes. Once you do this, so the therapist scans the Phantom, you send the data to Pinnacle or Eclipse or RayStation or whatever you may have. The dosimetrist or the physics, if you're the one doing the treatment planning, you should be the one planning that. And then the therapist will take it to the machine, and then you deliver your plan to it. You send the Phantom in, and you get the results a couple of weeks later. This is a recent Truebeam machine that we got in our clinic. We do this for all our machines, and anytime we have a new treatment technique that we introduce in the clinic. And so, you know, everything looks pretty good. They have a very loose tolerance. That's one of my gripes about it. It's plus minus 7% for the gamma, and 4 millimeters for the distance to agreement. And there's a reason they did that. There was a paper by Andrea Molyneux in 2013 in MedPhys. She looked at 10 years data. So this has gone to many, many institutions around the world. Initially, this was only for the NCI patients, putting patients in protocols, but now anyone can ask for this Phantom and get it. It's been irradiated 100,1139 times by 763 institutions. Only the head and neck Phantom. They also have other Phantoms available. Only 82% of institutions pass the end-to-end test with the head and neck Phantom on the first irradiation, which was not very nice, with such a loose tolerance of 7% for the TLD and distance to agreement of 4 millimeters. Over the years, people have improved. People have understood the treatment plan system a little bit better. Beam modeling is better. The vendors have come up with better models, and have tried to fine-tune their algorithms and things like that. And so initially, 2003, there was only about 65% passing this Phantom, and 2012, it's almost 85%. Usually, they're on the cooler side. So the TLD divided by the institution. So the TLD is lower than what the institution is claiming, the treatment planning system it is. So this is 1 right here, and it's kind of about 2%. That's where the peak of this curve is. And as you can see, there are some institutions that are 10% off on either side, and that's not a good thing. I mean, they're treating patients with this. So how accurate is their treatment planning system being commissioned? If you look at the distance to agreement, again, there's quite a few of them within the couple of millimeters, which is pretty good, but there are also some institutions that are pretty bad. They're more than 6 millimeters. Carson was a student, a grad student in our department, worked at the IROC for her research, and published this in December 2016 in Medical Physics. It's a fairly new article, and showing you that the institutions that failed, most of them are systematic issues, and most of them are underdosing. The one in pink, the line in pink, is the institution treatment planning system, while the dark line is IROC FEM measurement. And so they normalized the FEM to the TLD measurement, and in this case, in this particular institution, was 8% low. And so this is a systematic error in this person's treatment planning system, in this institution treatment planning system. And there are also some global errors, some setup issues, where some things look good, but suddenly something is off right here, and then here with these horns. And so they're going back to look at these specific institutions and see what exactly was wrong with them. Cause of failure, some treatment planning system, Linac combinations did better than others. Most detectable errors systematic and dosimetric, so that is one thing they found out from this study. Cause of failure included incorrect data entry into the treatment planning system, so things were wrong. The data went in like a garbage in, garbage out, wrong PDDs. Inexact beam modeling, MLC leaf modeling, which is a big one. Software and hardware failures, inexperienced qualified medical physicists and dosimetrists, IMRT implementation incorrect, gross setup errors. So, and then she indicated, so they're trying to look, so IROC is trying to minimize, they're trying to decrease that threshold from 7% to 5% and to 4 millimeters. So they looked at that, if they had changed the tolerance to this tighter tolerance, now 77% of institutions will meet the criteria today. And that's not good, that's almost 24% of them failing the criteria with the tighter spec. All right, so I'm going to change gears now to treatment planning. And so that was just about, so the main thing, the take-home message there was do an end-to-end test and let somebody else, let a friend, somebody else come in and look at your data and things like that. It's always, the second pair of eyes is very important. It doesn't matter how experienced you are. People make mistakes. I make mistakes. Okay, that's the key take-home message there. As far as treatment planning goes, third party could be anyone. There are many times I've seen different, if someone is not treated by the same physician, physicist, dosimetrist, any parameters change as third party. Suppose the person is scanned in diagnostic imaging and then makes his way down to your IROC department, it becomes a third party problem. And there are many areas that things could go wrong, and the main thing is communication, and I'll kind of talk about some of that between the different groups. So the main treatment planning phases, treatment intent, disease staging, previous treatments. Previous treatments is a big one. Suppose a patient got treated before and sees a physician and says, "Hi doc, I got treated before." And then that doc says, "Okay, now you can go and see my friend, colleague in the department," but forgets to mention that piece that this patient was treated before. That's a misadministration because the patient is going to come in, you're going to treat without having any idea that the patient was treated before. And so that's very important that as soon as you find out a patient's treated before, you need to communicate it to everyone and get the previous records. Patient position and immobilization, image acquisition, registration input in the treatment planning system, the contouring, anatomy delineation, the technique, those constraints. I have a slide on each one of these different points. So like I said, if the same team is even in one way different, then it becomes a third party. It doesn't matter if it's a colleague in the same department. If a patient has a pacemaker, prosthesis, or is pregnant, or needs anesthesia, this information we document upfront and include during the entire process. Because a pacemaker, you don't want a treatment field with a high energy like 18X to be right near the pacemaker because the pacemaker can fail. And so, if sometimes these things get lost in translation and the information doesn't go down the chain of command, and so that's very important. So we take it very seriously upfront. When the patient is consented, we document upfront whether the patient is a pacemaker or not. Prosthesis is important because the patient comes in, gets scanned, suddenly you see this artifact, and then does the patient need an MR, or does the patient need tomotherapy or high MV CT? Or should we use OMR scan, metal artifact reduction? All those things need to be answered. If the patient has a claustrophobic problem, or the patient is pregnant, what do you do? So communication between all involved parties is key. That's very important. Position and immobilization. Sometimes patients get simulated in one area in one CT scan, and they may go to a satellite hospital a few hours and get treated there. These immobilization devices have to travel from one area to another by some kind of transportation, and sometimes they may get, they have backlog bags, and they may leak. And so, all that needs to be taken into consideration. The physician needs to have simulation directors tell the simulating therapist exactly what they plan on treating, what anatomy, what the PTV is, where the isocenter is up front. It can't be left vague. Ideally, the physician should be at the simulation for every single patient. So at MD Anderson, that's a rule that we have in place right now. If not, the therapist will not simulate the patient. You need to talk about the organs at risk, what are you trying to treat, the technique, that's the 3D CRT, IMRT, VMAT, SBRT, et cetera, up front. If bolus is needed, John kind of talked about electron bolus, so if that's needed up front, or if it's a chest wall case, if it's a simple bolus case, you need to let the therapist know up front so they can include that in the scan if needed. Patient couch weight has become a problem now because we have different, like exact track couches have a lower weight limit, and so the simulating therapist needs to know that up front so they can, when they put the patient on a schedule, they know the weight of the patient, the limitations of each different, different couch have different limit. Truebeam couches have different limit, the old Varian couch have different limit, Electa has a different limit. So you need to have all that up front at the simulation stage. Image acquisition, registration, input into TPS. Bore size is important. If the patient is large, you need to make sure what are you going to do at simulation. Ensure patient CT scan extent is sufficient. So make sure that if the tumor is there, that you go sufficiently above and below the tumor and you scan that area. So you don't want to shortchange. So the physician has to be there. If this patient was scanned somewhere else, that information doesn't go through the system. 4D seating, does the physician want motion management? Do they want a 4D CT? You need to make sure the connectivity between CT scanner and the treatment planning system is there. Your PAC system, the data has to go through. So if you're scanning the patient at a different center by some other therapist and transferring it to a treatment planning system in a different area, there are a lot of, just like physics consulting services, there's dosimetry consulting services. At a Southwest chapter meeting, there was a booth, and there was a dosimetrist who used to work at UT Southwest. He started this company as a dosimetry consulting service. And so here, he has 6 dosimetrists employed. And so sometimes the treatment planning system may be in their house or somewhere else. You need to make sure there's connectivity between your scanner, your data, and going to their treatment planning system and the information coming back. Plus, you need to make sure that their system was commissioned correctly as well. Contouring, a physician should use the standardization. We have different ICR 83, Astro 2009, AAPM TG 230. There's some standardized nomenclature, because if many physicians start playing around with the same patient, you get all kinds of naming schemes available. You need to make sure that your appropriate PTV and ITV are contoured and organs or rigs have been contoured. If there's so many densities like fiducials or prostheses or density artifacts, you need to override those densities. And then if you need fusion, you need to make sure that you're using your fusion software has been, again, checked and QA'd before you just start using it. As far as dose calculation, I won't say too much about this because this is kind of a black box. Treatment planning system already doing this. If you commission your treatment planning system correctly, this should be working correctly. Except one thing is the dose grid size. You need to make sure that you're consistent, that whoever's doing your treatment plan, you need to, if it's a head and neck or a complicated case, you want a 2 mm grid size versus a 3 mm grid size. Sometimes people, the dosimetrists might want to finish the plan faster because, the smaller you make the grid size, the computation time goes up. And so you need to make sure that you have some policies in place to have a fixed grid size for a certain body location, a body site. As far as dose constraint and goals go, have appropriate dose constraints. This is kind of important. There was a document jointly done by AAPM and Astro. It's called Quantec, Quantitative Analysis of Normal Tissue Effects in the Clinic. And this was published in the Red Journal in 2010. There's a picture of it. They looked at 16 different anatomical sites in the body. And it's a very good starting point for your clinic. If you don't have any dose, well, hopefully not. If you don't have any dose constraints, you can go back here. And again, this was done many years ago. Things have changed now with the IMRT VMAT things. We're getting a little bit tighter. But this is a good starting point. So this is just one table from there showing you rectum, bladder, penile bulb. It's a very large document. The whole journal is just dedicated to dose constraints. And you can look at volumes that they looked at, and they looked at end effects and stuff like that, and come up with some recommendations. Finally, the plan, check, and evaluation. So somebody else did the treatment plan, a dosimetrist sitting in their house doing this treatment plan, sending it to you. You need to make sure that this is all verified. But again, you need to make sure the treatment plan system has been correct, quality assurance has been done on it before that. These are standard things that you and I check on a standard, so I won't spend too much time on it in the interest of time. While I was doing this work, I kind of ran across this paper by Kevin Moore. This was some work done when he was in WashU, now he's at UCSD. And I found this kind of an interesting concept. So what they were saying here is that before the treatment plan even goes to your IMRT and VMAT QA, you can try to clean up the plan ahead of time. And so this is a very simple concept. There are other people who have also done research in this area. It's a geometric-based dose prediction tool. And so the basic concept is if you have your PTV, let's assume this is your PTV or your prostate, and the OAR is your rectum. Because the PTV, there's some margin to it, 5 mm margin posteriorly that goes into the rectum. So now you have this rectum in the PTV, and that's the overlap area right here. This also is the case in the parotid gland and head and neck cases where you have the parotid eating into the GTV area. And so they came up with the concept, so this area right here is pretty much going to get the full dose of the PTV. And then this is a gradient right here once you go away from it. Some cases, on some patients, this might not be too close to each other. There might be some separation. There might be some fatty layer between the prostate and the rectum. And so obviously this is not an issue with those cases. So what they did was they analyzed previous plans. They looked at previous plans in the clinic, then developed and implemented a model to predict OAR dose in advance for new patients. They came up with a simple equation. It kind of blew my mind when I was looking at this just this week, preparing for this talk. So I'm going to go back and try to see if it works in our clinic. And what they did was they kind of came up with a simple concept. The predicted dose divided the prescription dose equal to 0.2 plus 0.8, 1 minus e to the minus 3 overlap. The volume overlap is this area right here. The treatment plan system kind of gives you that area, the volume overlap, divided by the volume of the OAR, which is the primary. In this case, is the whole volume of this right there. And then this curve is kind of, they found out that this was a parotid and head and neck combined. They came up with this curve. This is like the optimal curve. And before they did this training or prediction, this is what their results look like. The standard deviation, a lot of noise all over the place. Once they put everything through this equation, this is what they got. And this was before and after this was the rectum case. And then here is esophagus, larynx, parotid gland, bladder, and rectum. And you can see, by predicting, they started getting tighter and tighter results and better results. And so they were claiming that the organs at risk is what gets, because physicians are mostly interested in PTV, and the dosimetrists or physicists don't spend too much time on trying to improve on the organs at risk, trying to minimize the dose that they're getting. By using this predicted model, and you can achieve that. Another person from the same group, also published in 2012, basically is claiming that metrics can be developed using previous plans to alert users that the current plan is suboptimal. It's almost like machine learning, you're kind of training. You have to use old information from old patient sets, combine that information, come up with some kind of an algorithm, validate it, and then you apply it to newer cases to see how it works. And so this was clinically approved plan in that case. The blue dotted line is a predicted parotid DVH. And this was after replanning, they got even a better DVH. So here they improved less of the DVH is getting more dose. Obviously, the quality of life of the patient is improved. So it's a very nice, it's very simplistic. There's more complicated ways to do these things, I'm sure, these days. But at least it's a start. The last topic I'm going to talk about is brachytherapy. There's about 200,000 men get prostate cancer every year. About 40% of these men will receive prostate implants. There are many third-party products, again, in this area. You have the ultrasound that comes to your system. You may not have any ultrasound experience. The vendor may commission the machine for you. Again, this is not correct. You as a physicist need to learn ultrasound, how to use it. You need to commission the equipment. You need to do annual QA. TG128 is a very good document, completely dedicated for ultrasound QA. And so you should go in and you can get a CRS Phantom. It's an ultrasound Phantom, which has got different wires running through it, different prostate sizes that you can actually go in QA. And you can also create a grid using it, and they're giving you some action levels. The treatment planning system, you can have a Symphony, a Variseed, some of the bigger brachytherapy prostate implant treatment planning systems. What you do is you scan the Phantom, and then you can also try to contour the Phantom to look at the contours to make sure the anatomy is correct. You can do some isodose verification, and you can do an Excel spreadsheet sitting in your office. Put a seed in there, look at the dose at a certain point. You can do this in one or two source location, but once you go more, it gets a little bit more complicated. But this is a verification, an independent check of the treatment planning system. So just because somebody gave you the treatment planning system and said it's commissioned, you need to go and verify that it's working correctly. When you order seeds, we do typically strands in our clinic. The needles come in. How do you know that the source is exactly in the needles? You can't just accept what the vendor is telling you. And so you have the treatment plan. This is the treatment planning pattern for this particular patient. And this is a QFM of this. And you can see the sources, where they're supposed to be matched up with the actual what you intended. In addition to that, you don't know the activity indices. You can't just trust the vendor. Obviously, they're a company, a business, they want to sell their product. Most people are trustworthy, but still, you need to verify that these assays are correct. So the variety of options available for source and applicators. The first is aware of the different assay requirements of sources that are loose, stranded, or ones that are preloaded into needles. So there are many ways to do prostate implants. You can have the MIC applicator that uses loose seeds. About half the country uses loose seeds, and half the country uses stranded seeds, pre-planned, preloaded needles. Third-party vendors are there to process. They're called pharmacies, and they'll do this. AAPM TG56 recommended a random sample of 10%. So this is some old information. You get 100 seeds, you randomly pick 10 seeds, you assay them, and then you put them back in the batch, sterilize them, put them in the cartridge, and you're good to go. Since then, things have changed, evolved a little bit more. There's some new documentation as to how many seeds to QA. If you're using stranded seeds, this is kind of what you get. You have a well chamber. You have a chamber holder that can hold a loose seed or a strand if you want. You can also get the vendor to give you 100% assay. So you as the customer can demand anything that you want up front before you start signing the contract. After that, it's too late. So we ask the pharmacy, a third party, not the vendor. Vendor sends the seeds to another company who will do the assay for you and load them into the needles for you. That's available as well. And then internally, we do our own QA as well, randomly with 5% of the seeds because we use strands, and we check our QA. And within 3%, we're okay. So there's, by Wayne Butler, there's a nice article from the Brachytherapy Subcommittee from AAPM in 2008. So they're saying if you lose all loose seeds, non-sterile, you can do 10% like before. Nothing's changed there. Same thing in the non-sterile cartridges. If you have a mixture of non-sterile, loose seeds, and sterile assemblies, they get 10%. If you use sterile source assemblies, that's the strands, or this. These are both more or less the same thing. It's 10% assembly via sterile well chamber, inserts, or quantitative image analysis. So basically, you can just put a strand, one of the strands, but by doing that, you kind of take away the sterilization once you open the kit. And we don't like to do that. So what they have, there's a workaround. They state that alternately order and assay non-sterile loose seeds equal to 5% of the total or 5 seeds, which was fewer. So from the same batch, so I'm buying 100 seeds from the vendor, it's going to the pharmacy. In addition to that, they'll send me 5 seeds, if it's 5% of the 100 seeds, and I'll assay that. They need to be from the same batch that those other seeds were generated from. So typically, it's usually 3% or better, sometimes 4%, but I've never seen it worse than that. If you're looking at individual seeds, it's usually, if it's less than 6%, do nothing. If it's more than 6%, you can talk to the consulting radiation oncologist. If you're doing a batch of seeds, if you're doing 100%, if it's less than 3%, do nothing. Again, 3% is pretty good for random. These seeds are hard to make, and they got short half-life. Like CGM-135 has a 10-day half-life. So if you're a few hours off, your activity may be different. If you're between 3 and 5%, investigate the source of discrepancy or increase the number of your QA. And if it's greater than 5%, talk to the vendor, see what the issue is. And usually the vendors are good. They'll call you and say, hey, there's a problem. And talk to the rad-onc and see if you want to change the treatment plan based on the activity that you found. So in conclusion, there's an increased use of third-party radiation therapy products and services. There's nothing wrong with that. The need is there. These products and services play an important role by filling a need due to lack of well-qualified fill in certain areas. Also, administrators like to use third-party. It is all right to use third-party products and services. However, these products and services should be thoroughly validated prior to clinical use. So the take-home message is use all kinds of vendors for whatever you may have, but it's your job as the physicist to verify what they're giving you is correct for every patient. Okay, thank you.